medical registrars. And the reason why I'm doing this is because we all struggle when you start as an F1, but then you do get better sort of after a month. It doesn't take long. But it's that first month that is really painful because you just have no idea what to do. And you waste a lot of time doing tests and tests and tests, which are actually, none of them are important. So then I just want you to sort of concentrate on prioritizing what's important when you're on call. So this is mainly an on-call situation, but for the 4th years, it would be really useful for you to know what to say in your ISCI situation. So because that's more clinical, and what we do is more clinical. And as I've done simulation with the two of you today, where I realized that I've done more simulations with the last MAU lot as well, where I realized you guys know a lot of things, but it's really hard for you to apply it, and that's the reason why I'm doing this. So what I want you to do when you go through this with the consultants later on, or my other colleagues, my other SHO colleagues, just think of when you are doing that particular thing, think about what you're actually doing. And also you have to be really specific about things. And I've told you guys today from the simulation, you have to be really specific about, if you tell the nurse that I want this, what do you exactly, I'll put some oxygen. What does oxygen mean to us? Do you want to put a 2-liter wire nasal cannula, or do you want to put a 28% Venturi mask, or do you want to put a 60% Venturi mask? So those are quite important things, because if you just say oxygen, it doesn't mean anything. And if you're going to put up fluids, you have to be specific about, are you going to put Hartmann's, are you going to put normal saline, and exactly how much you want to put it through, and exactly how long you want to put it through. So those are important things, because you can't just say, yeah, just put the fluids, just do whatever you want, because a lot of nurses, they are quite protective of their own numbers. So you have to be really specific about those things. And don't worry about ringing your senior colleagues. You are going to meet senior colleagues who are going to be really nasty to you. And you are going to meet colleagues who's going to feel like, oh, why are you asking this, or why are you asking that? And I've told the simulation today, you have to be really specific about what you want from your senior colleagues. You need to tell, for example, if you ring the endoscopist, you need to say, do you think I need an endoscopy for this patient? And not just ring the consultant and say, I've got a patient with upper GI bleed, blah, 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 and then just end there, because that's what we do usually. And then the consultant will be like, okay, so what do you want me to do then? So you have to be really specific. If you ring the medical registrar, when I ask you a question, if you don't tell me exactly what you want me to if you don't tell me what exactly you want me to do, I will be a bit like, okay, so what is your question? So what do you want me to do? And it's not very nice when someone asks you, what is your question? And then you're going to just feel like, I don't know. So before you ring someone, just think exactly what you want them to do. For example, if you want the medical registrar, can you come and review this patient, please? Because I don't know what to do now because I'm stuck. Then yes, I'll come and review the patient with you. Or if you want if you just want the registrar to look at your chest X-ray, fine. You can ask them to say, can you have a look at the chest X-ray? Be really specific about what you want, okay? And that would be really useful. And not everyone is as patient. So I'll start with temperature, because you will get a call, definitely. Temperature of 38.5, temperature of 38, temperature of 39. Can you come and review this patient, please? And when you're the F1, usually what you do is you go in, you reclark the patient again, which will take you an hour, and then you do all the blood tests, you do all your blood cultures, you do all the bloods. It will take you another half an hour. So then you only have 5 hours, your cover shift from 5 to 10 o'clock, for example. Then you have got 5 other patients to see. If you spend an hour and a half for a patient, you only have 3 patients. You can only sort of see 3 patients during that day. So it's not very helpful. So that's the reason why, one of the reasons why I'm doing this as well, to just let you know that a lot of things you can actually hand over to the next day. But you just have to be quite careful about handing over as well. Because some things, if you're really free, do it. If you're not free, you can hand over. Okay? So if you've got a temperature of 38.5 or anything above 38, if you hear 37.5, usually what I do is, okay, is the patient unwell? If the nurse say, no, the patient is well, then I'll be like, okay, just monitor for the moment and see what happens. And can you repeat the temperature sort of an hour or two later? And if the temperature goes up, can you let me know again? So that's what we usually do. Then you can actually just bat it off. Then an hour later or 2 hours later, temperature will come down to 37, and then that's fine. You don't have to worry about that. And when the nurses ring you, don't just say, I'll come now. Get more information, because while you're walking to the ward, that's when your thinking process is going on, because that's when you start thinking, okay, what is the problem here? So what I usually do is, if the nurse doesn't have the notes in front of them, I'll say, can you get the notes, and then can you just tell me exactly what the problem is? So it's really important for you to know what the patient's background is, past medical history, and what they came in with. You don't have to know their social history, you don't have to know their family history. All those are important when you're clerking a patient in MAU or in SAU, but not when you're on call. If it does sort of affect your decision making, then that's fine. But while you're on the phone, that's fine. Just ask what their medical problem is, and what they came in with. And then what their current treatment is. So are they on antibiotics? That's always the first question I ask. Then if the nurse say the temperature is 38, are they on any antibiotics? Yes, they're on levofloxacin. How long have they been on levofloxacin? They've been on levofloxacin for 12 hours. Fine, can we just repeat the blood cultures? That's it. I don't have to see the patient. Whereas if some of you are inexperienced, some of you will worry and say, oh, if I don't see the patient, what's going to happen to the patient? So then you can just ask, like, okay, so what is the blood pressure, what is the heart rate? If they're all stable, then that's fine. We can repeat the blood cultures, send it off, and then we can re-review again. But it's different. If the patient has been on levofloxacin for the last 4 days, then that will be a completely different thing. Then that will make you think, okay, is there something new going on that I need to go see this patient? But before you go see that patient, you need to ask them, okay, so what blood pressure, what's the blood pressure? The main thing is mainly the blood pressure, really, and then followed by the heart rate and the respiratory rate. And then while that's going through, and ask if the patient has new confusion. So why is it important for us to know if the patient's mental state is sort of normal or abnormal? Can anyone just shout out?
End organ damage?
Yep. So then the other end organ damage, sort of what are the signs that you would ask?
Urine output?
Urine output, yeah.
Would the nurses know a lactate or not?
Possibly, they might have a VBG from this morning or something like that.
It's worth asking them.
It's worth asking, but if they are quite busy and you want them to rummage through the notes, then maybe not. But usually you're sitting in front of a computer, so the VBG will be in front of you. So you can look that up yourself. I usually when someone refer me a patient to see, I usually just look up the computer and just don't bother listening to the full blood count and everything, because everything's just right in front of me, because it would just waste my time. So ECG, so chest pain, so end organ damage. So one of them, your heart might be affected. And the other stuff are like your liver, whether they look jaundiced or not, and stuff like that. So then if they have been on antibiotics, if the nurse said that, oh yeah, it's the same symptoms, then you're reassured, because that's what they came in with, isn't it? So there's no new symptoms. So then you will be slightly reassured by that. But if they have got a new symptom, then you will ask, okay, does the patient have any new symptoms? They say, oh yeah, they're coughing a lot more now, despite being on, for example, amoxicillin. So then maybe you want to think of, okay, maybe amoxicillin is just not working for this patient for the last 4 days. Then maybe I need to increase it to Augmentin or perhaps Tazocin. But if they've been in the hospital for more than 72 hours and they're not getting better, usually we just go to Tazocin, because Tazocin it's a broad spectrum antibiotics, and it covers a lot of the hospital-acquired type of infections. And ultimately, you have to ask them whether they are unwell or not, because if they are unwell, no matter what, if I trust most of the nurses, and if I know the nurse really well and they say I'm just really worried about this patient, I will usually just go straight away. If I'm not stuck in resus or if I'm not stuck in a cardiac arrest, then I will usually just go straight to see that patient. So from the patient itself, you would get, so what you really want is to get the history from the patient, so source of pyrexia. So the answer is all there from the, I was going to ask you this question, but the answer is all there on the physical examination. So then the main things that we look at is your cardiorespiratory infections, and any abdominal infections, so any UTI or any C. diff infections, and joints, things like septic arthritis is quite unlikely in a hospital setting, but then sometimes we might miss things. So when you see the patient, it doesn't take you 5 minutes to just quickly just look through their hands, look at the JEP, look at their eyes, look at their heart, listen to their heart, and their lungs, do a quick abdominal examination. With your neurology, you don't have to do a full neurological examination. If they're moving all 4 limbs, and do a quick plantar reflex, because those will just save a lot more time. Then if you have really strong suspicion that the patient is encephalopathic or encephalitic, then do a full neurology. And then things like, just have a quick press on the spine, because discitis is also one of the things that we do miss. And medications, so things like immunosuppression, so those things, if the patient is on steroids and stuff like that, so it's really important for you to know. And the reason why I put medications there as well, if the patient has hypotension, what are the things that you will stop?
Antihypertensive.
Yep. So antihypertensives. So and that's the thing. So I remember when I was an F1, I don't usually look at the drug chart as much as I do now, and I don't really rationalize because I didn't know how to do that. So basically, just look at drug charts, see what are the things you can stop. The medical approach and the surgical approach is very different. So we're quite conservative and we like to stop things because we don't really like to overdose our patients or give them too much polypharmacy. So then we look at things that we can stop. So if a lot of those things that you think the patient they don't need it, then just cross it off. And if for example, they're not swallowing and they're really drowsy, and then you've got omeprazole, you've got this allopurinol, and then you've got all this aspirin and stuff like that, actually, even if you stop that for a day or 2, is it going to make a difference? No, because then what if some of the nurses trying to feed the patients and they aspirate? So then there are a lot of all these little things that if you have the time, consider it. But if you don't have the time, don't worry about it. Because when you're on call, you're just overwhelmed by a lot of things. Because you'll be running around as an F1 on the first day, you just sort of run around and like, what do I do here? What do I do here? And then if they are unwell, get a portable chest X-ray. Okay, if they are unwell and you need to think about, yes, I want a chest X-ray, but then that's it, we stop there. But then you actually have to think that how are we going to transfer that patient to the X-ray department? If they have got a blood pressure of 80 systolic and a heart rate of 140, and they say, yeah, get a chest X-ray, and then the nurse is actually going to wheel the patient to a chest X-ray, are you going to send that patient to chest X-ray department? So no, so you need to think about these things. So portable chest X-ray will be really useful. And again, ECG to look for end organ damage as well with ischemia and sort of tall QRS complexes. And then a urine dip. So those are the things that you can sort of get from the patient. And
when you say when they're too unwell, you need a portable, I always struggle with when that line is, like when are they too unwell?
So what I do is I follow my gut instinct. So you, I'm sure some of you just see some patient, they just lie there and you're just like, he's not doing well. Those are the patients that you're going to like, yes, portable chest X-ray. Look at the parameters. So if your blood pressure is sort of 100-ish and your heart rate is really high, about 100, 130, then I would be a bit sort of worried that if I send him off, and what if he drops his blood pressure to 80 when I sort of drop him off in chest X-ray. But things like CT scan and stuff like that, sometimes you do have to do that. Then if I were you, I would go with the patient myself. So that's one thing. So you're busy, and I think that's what we are trained. We're busy with doing all these little things, but actually in the end, your patient safety is your number one thing. So then if you want a CT scan for that patient, if a consultant says, yeah, the patient really needs a CT scan while they're unwell, go with the patient. I can't, it's mainly based on experience, but if you think the patient is just not going to thrive if you leave them alone, then that's when you know that it's portable chest X-ray is the right thing to do. But even if you make the wrong call, to be honest, you know what? It's something that you learn slowly, and it's not going to do much harm. A chest X-ray is not that much of radiation, really, isn't it? So that's one thing. And so sepsis 6. Do I have to move? Do I have to do that as well?
Oh yeah.
Whoops, sorry. So I'm not going to talk much about sepsis 6 because you guys know about it. So give 3 and take 3. But the thing is, you have to repeat the lactate again later on. So don't just do one lactate and say, oh yeah, that's it, done, my sepsis 6 is done. No, you need to repeat it later on and see whether the patient gets better later on. And always reassess your patient. Go back and reassess your patient. Even if you're off shift, like 9:30, for example, you're going to handover, it's always best, even if you don't have to see the patient properly, just go back and just have a quick look at the ops chart and see how they're doing. Then at least you can go back and have a good night's sleep.
Sorry, did you say a timeline to review?
No. So it's just, if you, for example, if you say, oh, give the IV, so how you judge it. So for example, like if I'm going to give IV fluids for an hour, for example, 1 liter over an hour, then come back an hour later, and then just see how their blood pressure is doing. So we're sort of treating how well they look like, and then whether their heart rate is going to come down, and whether the blood pressure is increasing. So you do have to go back from time to time. I'm not going to talk this in detail because you guys know all these things. It's just, it really annoys me a little bit when people say patient is septic, but actually patient is not septic. So then you if they meet SIRS criteria by 2 of the SIRS criteria and they've got a source of infection, then yes, there's sepsis. So just be really, be more specific about this thing, okay? When to start antibiotics. So when you're on call, sometimes if they're really well, and you don't know where this is coming from, and it's a one-off temperature, actually, you know what, just step back and just watch for the moment. And then you can always recheck the temperature again 2 hours later. And then if it's high again, then if you're really worried and they start getting on well, then you can start broad-spectrum antibiotics. It's fine to start Tazocin depending on where you think they are. So for example, in this hospital, we use Tazocin as the hospital-acquired type infection. So it's fine to just give 1 dose or 2 doses of Tazocin because we can always recheck the cultures and everything, and then we can always refine, as in choose the right antibiotics for them. So don't feel bad and say, I want to start antibiotics, but I don't really want to start. Just start something, and just see if it's hospital-acquired pneumonia or hospital-acquired infections, then it's usually the more broad spectrum, such as Tazocin. But if they come from community and they've just been in hospital for less than 24 hours, and then that's when you start realize that actually I think they've got pneumonia, then start on a less, not Tazocin, but in this trust we use Augmentin and doxycycline for chest infection and pneumonia. Or you will always have a trust guideline. So always look at your trust guideline. It will tell you cholecystitis, start what antibiotics, UTI, start which antibiotics. So follow that because the local resistance is different. So if you know a source and they've been started on the right antibiotics, for example, you go there 3 days later, they are on Tazocin, and then you look at the blood cultures. So always look at the blood cultures from the past. Just while you're looking at the bloods, just go really quickly and go a couple of years, a couple of years before the admission, and just look at the urine culture and the sputum culture and stuff like that, and look at the MRSA status. If, for example, like if the patient has a urine culture, and you think that this is a UTI, and then when you look at that urine culture, if they've got a sensitivity of, for example, Augmentin to E. coli, and they've always been colonized by E. coli, then it's actually really helpful for you guys to know that actually this patient might have UTI, and then Augmentin might be the right choice because that's what they've always been sensitive with. So that's something to look at. And if you don't know what's going on and you don't know where they are, just ring the microbiologist. You might get someone who's really grumpy, but you know what, just suck it up and just tell them, I'm just really worried and I don't think that we're on the right antibiotics. And don't take it too hard, okay? And that's what I've said. And also always look back at their culture from when they come in, because sometimes the day team, and I do that as well, we always forget to look at their sensitivity because they have been sent by MEU, they've been sent by ED, but then we forget to check them and they come to the ward and they were like, well, they're improving tetracycline anyway, so just leave it. Or sometimes then they start deteriorating after they are sort of, in the morning they might be improving, they thought that they are improving, but actually when in the evening when you see the patient, they're crashing. So that's when the time when you look back at the culture and say, oh, well, actually, they're not sensitive to augmentin, they're resistant to augmentin, they're more sensitive to levofloxacin, then you can just confidently change that to levofloxacin. But always document. So the main thing is to document and justify why you're doing things. Okay. If, for example, you've seen the patient and they have been on penicillin for the last 10 days and they're still spiking temperature, and that's when you start looking at things and you look at their CRP. CRP might be 20, it's not that high. So, and then you're wondering why are they spiking temperature, or why do they keep spiking temperature? Sometimes if you stop the antibiotics, the temperature will come down. So penicillin does, if you take too much penicillin, it does bring up your temperature. So that's one thing. And the other thing is, so things like malignancy, sort of cancer patients, they usually do spike, and then you can never find where the sources are. So that's one thing. So just think about things like that. And clearly inflammatory disease, which Dr. Bosanko at the back will talk to you about IBD later on, and things like neurogenic stuff. So summary, just ascertain the urgency of review. So that's what you do. You need to, when you speak to the nurses, try and get as much as information, and then just ask them how unwell are they, and then just see how urgent, and then you can sort of gauge how quickly you should go see that patient. And know your sepsis 6, definitely. And consider holding off antibiotics. So what I mean is, don't start antibiotics straight away just because you just want to start something and just save the patient. Sometimes that might be the wrong thing to do, because then you might mess up all the cultures and stuff like that. So then if they're well and they just spike one temperature, then just give some paracetamol, give some fluids, sort of cooling techniques really, and then things might get better. If they start getting unwell, that's when you start antibiotics. And do a focus examination. Don't waste your time and do a full neurological examination. Don't waste your time trying to percuss and trying to do your vocal resonance and look for tracheal tug and all those things, because you're just going to waste a lot of time. And then when you ring anybody, not just the microbiologist, even if you ring me as a medical registrar, or if you ring the consultant, the endoscopist, know your history and ask specifically what you want. And that's my advice for you. Okay, thank you very much.
Give you some advice about how to manage these situations when they present as an emergency. So it's your first on-call cover shift. It's about 9 o'clock at night, and a nurse ringing you and said, "Doctor, I'm sorry to bother you." No, you're not. But I've got a patient who's got coffee ground vomiting. So the question to ask, as we've discussed before, is get a feel for the triage category of how important this call is, okay? The question to ask is, really is it coffee ground vomiting? I mean, lots of punters come in from nursing homes with coffee ground vomiting, and actually it's the beef and onion gravy that they had at lunchtime. So you really need to get a feel for whether this is a real event. As we've mentioned, if this call comes from a senior nurse, you take that hint that this nurse is worried, and you are humble and say thank you for that, because they've seen this a million times, you haven't, okay? Don't be that doctor that turns up on day one as an F1 with the doctor complex. It just doesn't work, and the nurses will spot you a mile off, okay? Observations. Is this patient hemodynamically unstable, in which case you need to down tools and go there immediately, okay? It's such an important piece of advice when you go to these emergencies that you've not seen before. So things like chest pain, MI, acute LVF, seizures, significant and catastrophic hemorrhage, they are really scary, and all of your medical knowledge will completely evaporate through the seat of your pants if you don't mentally rehearse what you're going to do when you turn up on the ward. So my advice is to think worst case scenario, okay? Worst case scenario is I'm going to turn up on the ward and find a patient exsanguinating in front of me with relatives and nurses screaming. What you need to be is that calm doctor. Even though you're shaking on the inside, you need to turn up with a sensible approach to dealing with this patient. I totally accept that you cannot definitively deal with the patient in your competence, but you have the competence to save the patient's life more than I do at this stage, okay? So the main goal for someone who's having a significant GI bleed, so this is a patient with active major hematemesis, and we're talking, filling a bowl, a paper bowl every 30 seconds with fresh blood. That is really scary stuff, okay? Or filling the bed with melena. The longer you wait, the minutes and seconds that you wait, the harder it will be to get good quality venous access. So that's the thing that you can do. Turn up on the ward, acknowledge the situation, and whilst you send someone to get help, so you would need senior help there quickly, just start getting some good quality venous access. The longer you wait, the veins will disappear and you're in big trouble. And within the levels of your competence, you start resuscitation, okay? Resuscitation, as we talked about millions of times in your ABCD, blah, blah, blah approach, in real life, it works, okay? You need to get some fluid into these patients whilst you're taking bloods, cross-matching, etc. These are inpatients, so we may well know the cause. This may be a rebleed from someone who's already been endoscoped, or this may be on the cardiac ward 2 days post whatever procedure, they've got an ulcer that's bleeding, okay? But this is real-life stuff. Assess a possible diagnosis. I'll come back to that in a second. Essentially, you need to assess your response to initial resuscitation treatment. So fluids initially and blood. And if the situation stabilizes, then everything moves to the next available inpatient endoscopy slot, okay? So the guidelines we work to is we should be scoping patients with significant bleeding within 24 hours, okay? The weekends are difficult and will change over time, but you're looking for the patients who are going to need out-of-hours endoscopy. And the way to do that is to assess the response to resuscitation. And if it's unsatisfactory, if they are hemodynamically unstable, despite a good go at resuscitation, they're going to need intervention. If their Blatchford score is significantly elevated, so above 3, definitely above 6, then you need to start to ask the question of the on-call endoscopy team, i.e. me. In the middle of the night, I'm desperate not to get out of bed and wade through the dreadful weather to come into hospital. And it's not purely self-protective, well it is, but the main issues about out-of-hours endoscopy, a lot of junior doctors don't appreciate the logistics of these type of exercises. It is very difficult to get these patients into theatre. There may be a trauma, there may be a laparotomy in theatre, we've got to wait our turn. And actually the theatre experience for doing endoscopy is poor. Okay, you've got a tired endoscopist, you've got a team around you that aren't endoscopy trained, the kit is suboptimal, all the toys, the bells and whistles, the nurses don't really know how to use. So the overall experience is less good than resuscitating these patients, stabilising them and doing them in the light of day in the endoscopy unit. Yeah? So that's our aim, it's a better quality. If the situation is terrible, they have variceal bleeding, they're going to bleed out, of course, and emergency endoscopy is the right thing to do. I personally don't care if a reporter rings me to ask for an out-of-hours endoscopy, but unfortunately, medical hierarchy is such that this is a phone call that should probably be made at a senior SHO registrar level. But your job, as I say, when you're seeing the patients, just to get them into that situation where we can decide, are they going to stabilise or are they actively bleeding and we need to intervene. The other thing that I want you guys to be doing when you see these patients, either in ED, MAU, or on the ward, is making a decision. Is there any evidence to support that this might be a variceal bleed? Okay? The only reason to say that is because the initial management strategy is slightly different. And I would prefer you to err on the side of caution and be proven wrong than to miss the potential variceal bleed. So what I do when I see patients is to see, is there a history of liver disease? Are they frankly cirrhotic? Have they had previous varices? Of course, that's how you'll treat them. But the patient that comes off the street who's unkempt, who's got a liver edge, who's an obvious heavy drinker, I'm going to assume is variceal until proven otherwise, because we need to give them terlipressin to reduce portal pressure. And actually, in variceal bleeding, the only thing that's proven to improve mortality out of everything, so endoscopy, bands, terlipressin, the only thing that improves mortality is antibiotics, just in terms of their overall mortality, basically to do with bacterial translocation around the varices. So terlipressin and antibiotics, you start early. We do an endoscopy, find it's actually an ulcer bleeding, we stop those, that's fine. Does that make sense? Do they have any evidence to support this being variceal? You would up your ante in terms of whether you speak to the on-call endoscopist, and you would give these 2 drugs, okay? Non-variceal, this is a bit of a grey area. There is no evidence, and NICE guidance would say we shouldn't be giving PPI before endoscopy. It's given like Smarties in ED. When anyone comes in with a nosebleed, they'll get IV PPI. I'm not really going to fuss about it. And if there's any planned delay, for example, if a patient comes in on a Friday, they're not unstable and the next available inpatient list is on the Monday, that's real life, then it's reasonable to give them PPI therapy, okay? There is role, and this is where you guys come in, after an endoscopy is done and we find a bleeding ulcer or an ulcer with stigmata of recent bleeding, then they need an IV PPI infusion, and that's really vital that that's written up, okay? Certainly at Derriford, there's a really nice pre-printed pro forma. All you have to do is sign it, and they get 72 hours worth of IV PPI. That would be an omission if it's not started on the ward after the endoscopy. Okay, we'll recommend it on our report, but we're not going to physically have the drug chart to prescribe it. Okay, that's vital. Transfusion, the recent guidelines are saying we should be less aggressive in terms of transfusion. So under transfusion is bad, over transfusion is bad as well. Okay, clearly in a varicose bleeder, what's driving that spurt of blood, which is either going to stop because we fix the hole or the blood pressure runs out, if we drive that with more blood, you're only going to make the situation worse. So aiming for a hemoglobin of about 70 to 90 is a reasonable starting point. Okay, don't over-transfuse. Anticoagulation is not a topic I can cover in this sort of session, but if a patient has a catastrophic GI bleed in front of you, messing around a patient on warfarin with FFP or vitamin K is a waste of time. They need Octaplex, and that needs to go through the haematology on-call person they're the gatekeeper because it's bloody expensive. You have to tell them the story, and they'll approve it or otherwise, and you aggressively reverse warfarin. Okay, we see far too many people who come down, or we gave them 5 milligrams of vitamin K. Didn't want to do too much. If they're very significantly bleeding, then you give full aggressive reversal of anticoagulation. Okay, any quick questions about GI bleeding? As I say, it's just assessment and salvaging them from the patient that's just about to fall off the cliff and go into arrest to a situation where we can see how the land lies. Are they going to stabilise? We can chill out, or are they unstable? They need emergency endoscopy. So refeeding syndrome. Anyone come across it? Anyone experts on refeeding syndrome? This causes confusion and a bit of unnecessary agitation. Basically, the concept is that if you go into refeeding syndrome, you can end up with Wernicke's or Korsakoff's, which can be a long-term, irreversible situation. You get dangerous problems arising from low phosphate, potassium, and magnesium, and you can end up with bad fluid overload. Just a bit of background. We in this room will have enough thiamine for 21 days, but if you're malnourished, you're already close to total depletion, almost certainly. And once feeding begins, the carbohydrates you take in lead to usage and degradation of thiamine, and bang, you can very quickly go into Wernicke's and Korsakoff's. And then the other part of refeeding syndrome is related to insulin. Once you reintroduce feeding, you switch from fat to carbohydrate metabolism, and you get a big insulin release, and all your electrolytes do things they shouldn't do, and you end up with dangerous levels of electrolytes, which can lead you to arrhythmias, etc. Okay. Now, the reason to talk about this, as an example, in the Midlands when I was training, we saw a patient who was at risk of refeeding syndrome. That risk had been documented. Bloods had been requested on the Friday, Saturday, Sunday, and the bank holiday Monday. And by Tuesday, we turned up to find this patient was just on the verge of needing to go to ITU with full-blown refeeding syndrome. Anyone got any idea of why that might have happened? This is real life. The bloods were done. The blood results were documented, but nobody did anything about them. Okay, so diligently took the bloods and documented the results, but did not act on them. Okay, very, very difficult to defend that sort of situation. Okay. And what we need to do is to advertise the fact that this is a condition that exists and is important, and we need to encourage you guys to formally hand over. That's what the key is here, it's all about the handover. So we on the ward will identify, dietitians will identify this patient is at risk of refeeding syndrome, and that's because they've not eaten for 10 days, they have lost significant amounts of weight, they have a heavy alcohol intake, and we're going to either start them on oral supplements or NG feeding. There will be a plan to introduce ever so slowly. So fluids and nutrition will be introduced really slowly over a number of days. They will have had Pabrinex given to them before we start feeding. So hopefully that will all be set up. But the key thing is the handover for the results. So if you are on the gastro ward doing the jobs on the Friday, you need to write the name of the doctor you're handing over to and to say, I have handed over to cover doctor Jones and document in the notes to review and act on the results, okay, over the weekend. Just think of this, if this goes belly up, coroner's court, where's the issue lie, okay? If you're the person taking handover, then please just do it, okay? Review and act on the results. And don't get het up about all these numbers. Don't write them down. They're freely available on guidelines and on the internet. Basically, if you see that your potassium, your phosphate and magnesium are doing anything other than rising, then replace it, okay? Don't be worried about over replacements, okay? What you'll see is usually day 2, day 3, day 4 is when everything will drop, okay? So if on day 2 it's lower than it was on day 1, then give something. What do you think about Sandokai? Has anyone tasted Sandokai? Awful stuff. Phosphate Sandoz, awful stuff. Magnaspartate, ugh. So these patients are ill in hospital. They're unlikely to tolerate these terrible medications or likely to comply with them. So if you are seeing a drop, then replace intravenously, okay? And that, no one will criticise you at all for, and if they do end up in refeeding syndrome, we look back and say, well, they was given the appropriate treatment, and despite that, he's still plummeted. But that's really unusual. Just have a low threshold to intervene. Does that make sense? Yeah. So the potassium, phosphate, and magnesium intravenous supplements, and make sure that possibly if it's a precipitous drop, then you might repeat the bloods later on that day as well. Okay. But it's the handover is the vital thing. And the last thing I just wanted to cover in this little 20-minute slot is inflammatory bowel disease. So you'll come across 2 distinct types of patients. One will be a known IBD patient on treatment, hopefully on the gastro ward, but probably on a random outlying ward being completely ignored. Cynical. Or this will be a direct admission. So it's not uncommon for us to have a direct admission to a patient with IBD who will phone the IBD helpline, the nurse helpline, and will be arranging for admission. Because of the way the situation works, they may not come in for a few days, or they may come in out of hours. So it may be Marlborough ward here at Derriford. They arrive, they land on the ward at 6, 7 o'clock, and you'll be asked to clerk them. Yeah. Again, it's about worst case scenarios. So if you're called to someone with IBD who has belly pain, what's the worst case scenario? Patient with for example, ulcerative colitis. Toxic colon, perforation, disaster. Okay, IBD is a very, very hot topic, and complications from IBD are not regarded well at all. So in theory, we should be seeing very, very few people who end up in that disaster situation. So think about the worst case scenario, go along to the patient, exclude that worst case scenario, and you can relax. Okay. The key thing to IBD treatment and assessment when patients come in with a flare of their disease is to try and get a feel for the extent of their disease through the notes, whether this is proctitis, just the rectum only, it's much less likely to go terribly wrong, or whether they have a diagnosis of pancolitis. We need to exclude infection. So on day 1, we need to send stool tests. It doesn't necessarily preclude us giving steroids, but we need to send the samples. Okay, it's really frustrating if we turn up after a weekend and find that no stool samples were sent on admission, including C. diff. Really vital we exclude C. diff. And we are going to, it's very simple, treatment for a flare of ulcerative colitis or Crohn's that has resulted in someone coming to hospital pretty much always requires you to give IV steroids. So IV hydrocortisone, 100 milligrams QDS. If you're worried about infection, so if there's a high white cell count or if there's fever, then it's reasonable to add in some broad spectrum antibiotics until the stool cultures are back. So both strands. Make sure their X-ray is checked to make sure there isn't any frank toxic dilatation, and ask a friend if you're concerned. And the key thing is about once we put these people on steroids, these young patients on steroids, we may well dampen their ability to get peritonism, frankly. So we need to do serial X-rays. So day 1, day 2, day 3, and if things are settling, you can chill out. But you might see subtle increases in diameter of the colon, in which case we should be getting the surgeons involved for a review. And we often hold hands on these patients who are very ill at the beginning. It'll be a shared care between gastro and surgery until we know which way they're going. And the other thing is another hot topic about these patients and whether we should be giving them Clexane. So, an example, 20-year-old patient with known pancolitis presents with going to the toilet every half an hour, so sort of 40, 50 times a day, multiple times a day with frank blood, would you give them Clexane? Hands up for yes. Hands up for no. Hands up who's going to phone a friend. So the answer to this is that you must give patients with a flare of inflammatory bowel disease prophylaxis for VTE, okay? No matter how much they're bleeding. Why is that? They are wildly hypercoagulable, okay? They have a raised the massive inflammatory process, they're immobile, they are a sitting duck for venous thromboembolism. And if they get one, we as a hospital are in big trouble. Okay, this is a reportable incident. This is an audited thing nationally. Incidence of DVT and PE in IBD patients would be criticised to the hilt. Okay, so that's the only take-home message is that. Does that make sense? Okay, well that's all I had to say in my 20 minutes. Any questions?
You guys got any questions?
The key thing of dealing with any emergencies is that the nurses are your friends and they will help you if you are receptive and humble. They will give you little snippets to say, last time this happened we did this, or maybe you should phone your registrar. These are little snippets that you must not ignore. Okay, it's really, really vital. Good, okay.
Okay, so first of all, I know it sounds simple, but if a patient's in hospital, that doesn't necessarily mean they need IV fluids. You should only really be giving IV fluids to people who obviously you're trying to resuscitate or they're unable to take it orally. The two main things you talk about really are resuscitation and routine maintenance when you're on the wards. Replacement and redistribution as well are two other things which you've got to try and keep in the back of your mind. And they always drill into you about reassessing the patient as well when you give IV fluids. So that's obviously important as well. Going on to the next slide. So resuscitation, so I heard Dr. Sanko telling you a bit about this, and I'm sure you've all had it drilled into you. You know how to do an ATE assessment or approach. It is really important. When you're on the wards, I tend to find that your bleep will go off continuously for a few hours, and you'll get sick of nurses asking you to review fluid status, and there'll be one chucked in there with their blood pressure's 80 systolic or something like that. The key is when you start, you are going to be sort of a bit overwhelmed with everything that's going on, and you're not going to be able to take in everything, and then you'll put the phone down and you realise, I don't know anything about the patient, I haven't asked the nurse anything else, what are the other obs? It happens, it's perfectly normal, but it's just useful when you're on the phone to try and get as much information as you can from the nurse or from whoever you're talking to about what their obs are. Does the nurse know about what they've come in with? How are they actually doing on the ward? And what do they think is going on? Because some of the nurses are really good and they can tell you, this patient's septic and they need a fluid resuscitation, etc., etc. But when you go, when you take those referrals, always go see the patient, obviously, because when you start, you're going to be concerned when a patient has a systolic blood pressure of less than 90. I think when you become more confident, you sort of take it in your stride a bit more. But always assess the patient, look at their heart rate, blood pressure, and I think looking at the board, if they've got all of those things, I think you can be reasonably confident that they need a stat bolus of fluids. Even if I haven't taken much of a history from them, I would think if they fulfill all those criteria, I would just give them a 500 ml stat bolus of normal saline. And then once you've got those fluids up and running, that can give you a bit more time to think and take a history, full history and an examination, and look through all their notes, etc. As I say, with the 500 ml normal saline, when you are resuscitating the patient, it's important to take in. When you say give it stat to the nurse, it feels cool because you're a doctor and you can say things like give it stat, but no one actually knows what that is, because if you give it stat through they normally give it through a pump infusion that you see by the ward, and even if you're giving it at the maximum rate it's going at, it still goes in after over sort of 15 minutes to half an hour, which isn't fast enough really. So what you need to tell the nurse is to give it through a compressor bag, or for them just to literally hold it and squeeze it, and then it will go really quickly and you'll actually notice the response to the blood pressure. So as I say, once you've got the sort of fluids running, you think they need resuscitating, take a history. You're trying to work out, is this patient really depleted in the volume? Are they having excessive diarrhea, vomiting, etc., etc.? You're trying to reassure yourself that you're giving them fluids is the right thing to do. And if you've got to that stage where the blood pressure is 80 systolic and they're tachycardic, you probably are. Most acute patients in the hospital are their blood pressure is low because they're dry. That tends to be the case. Always ask about comorbidities, or if the patient's not able to talk to you, always try and find some time to look at whether they've got heart failure or kidney failure. Just because they've got LVF or any other form of heart failure does not necessarily mean that they're overloaded. They can still get dry, so it's important to remember that. And you can just, a lot of them can tolerate a lot of fluids. So don't be scared after one 500 ml bag of fluids not to give any other further fluids in a patient who's got LVF. Unless you're convinced obviously they're going into overload, then stop. I think NICE recommends that you can give up to sort of 2 litres in stat boluses before you should sort of speak for further help, really, speak to your senior. But I've noticed that the first bag, you notice a slight increase in blood pressure, and then after that, you have to give a couple more bags until you stabilise the patient. But obviously, this all depends on, is it an upper GI bleed? Are they dry, etc., etc.? Why are they actually fluid deplete? And so, obviously, in the examination, you can do a more detailed examination when you've got those fluids running as well. When I'm assessing this sort of fluid status, I always find listening to their chest is really key. Listening to the bases of the lungs as well. I don't know how confident you feel like that at the moment on the wards, listening to sort of bibasal crackles, etc. If they're in pulmonary edema, you see a lot, and obviously with heart failure patients. But it is something you just get more and more used to when you see it on the ward. And if you've got bilateral crackles on their chest and you're examining them, just be a bit more cautious about giving them further fluids. But you're supposed to tie it in with all the other information that you've got on the recent echoes and the past medical history as well. So obviously use the observations chart, drug charts. Sorry, that was the next slide. Getting on to the next, I forgot to do that one as well. Next slide, bedside charts. Look at the observation chart, drug charts. I find drug charts useful just obviously in determining how many litres of fluid they've had during the day. You can also, you think of stopping anything that would drop their blood pressure, or if you're resuscitating them or anything that's interfering with the fluid balance. In an acute situation, you can stop things like ACE inhibitors or blood pressure tablets. They're not going to, it's not going to harm them for not having a couple of doses or missing a couple of doses.
How do you actually do that though? Do you want to, say you want to stop some?
What do you mean?
Cross them out, say,
yeah,
say when they should restart?
So I literally just say, I cross out if it depends what time of the day obviously you've got it, but if it's like an evening or a night dose, I just cross it out for the night, and then in the morning, as long as it's not like an 8 o'clock in the morning, so i.e. before the ward round, i.e. when no one's able to review it, I'll put review in the morning dose. I'll put a box around it and I'll put review underneath it. And that normally means the nurses can flag it up in the morning. If I've forgotten or I'm not there, then the nurses can flag that up in the ward round and they can continue it or decide to stop it for a further couple of days. It very much depends on the situation. If they've got, if the blood's come back and they've got an AKI or something like that, you'll want to hold it for 48 hours. And I find that in a lot of situations you can hold these tablets for 48 hours, just cross it off for 2 days, and then review it after on the third day. But in sort of the acute, in that situation where you're trying to take in and assimilate all this information, it's not a problem for just crossing out on that evening dose and then having a look in the morning and getting the day team to review it, or depending obviously what time you're working. Urine output as well, obviously, so it's important to, I don't know, when you guys are on the ward rounds, you look at the fluid balance charts and you look at the urine output. I always find they're a bit of a nightmare to look at. and the consultants will ask you, you know, what's their fluid balance, and some of them are just you can't work it out from what the nurses have written, and you just have to do with what you can interpret from it, because the nurses will write excessive fluid losses and they'll write values here and there, and it doesn't correlate with, you know, how much input they've actually had, and it's really difficult because they don't write a net fluid balance, positive, or whether they're sort of deplete fluids either. So it's kind of up to you at that point really to try and make a sort of a decision as to whether they are deplete or whether they're overloaded. And you know, you take it in, if it's not clear from the fluid balance chart, just have a look at the patient and assess the patient and see what you can find and see what you think. Like I say, when you start on the wards, you're going to be inexperienced at this, so you're always going to be a bit hesitant about making these decisions, but as time goes on, you'll just become more and more confident with it. Next slide. So obviously, investigations-wise, you always want to look at, when I'm resuscitating a patient, I always try and have a look at their recent blood test results. Look at the FBC, U's and E's. I also have a look at a recent chest X-ray. It's not necessarily a problem if it's not a chest X-ray from that day. Look at previous chest X-rays to see if they've had any evidence of pulmonary edema, any evidence of fluid overload, and a recent echo as well. One of the things I find, and when doctors clerk patients in, is they'll get from somewhere that the patient's got heart failure. And then you'll look at an echo that they've had within the last week or the last few months, and it will say no evidence of heart failure, or they've got normal heart function. So I always go with what the echo says. You know, if the echo says they've got good heart function, they've got good heart function, and don't necessarily take into account what someone's written on the past medical history. But obviously, like I say, just because they've got heart failure doesn't necessarily mean that you shouldn't be really cautious about giving fluids if they're dry. They can still be dry, so don't be afraid about giving fluids. So that's resuscitation really. So it's kind of, I mean, it's simple really. It's a 500 ml stat bolus bag. If you feel that a patient needs resuscitation, which, you know, if you trust your gut instinct, they probably do need resuscitation. And the majority of acutely unwell patients are dry and they do need resuscitation. So just going on to maintenance fluids, next slide. As I say, maintenance fluids, when I started as an F1, I barely knew anything about it, to be honest. And I think I had a few lectures on physiology and etc., which I always found was a bit too much, or a bit complicated for when you're on the wards and you've got jobs coming at you left, right and centre, and you're trying to calculate, you know, what fluids you should give and why, really. So I'm going to try and give you a few tips as to what has helped me get through as an F1 and an F2, and what I think should work. So obviously, as I mentioned before, the patient doesn't need IV fluids if they're meeting their daily requirements orally. The temptation is for a nurse to come up to you on a ward, and it'll be after a weekend or even after a night shift, and she'll go, he or she will go, this patient's run out of fluids, can you prescribe some more? And it's tempting just to write up another bag of fluids, but you know, that patient's been eating and drinking for 3 days, and you know, you're just going to overload them, and then you create more problems for yourself later when they develop pulmonary edema, and you cause all sort of problems, and you don't really know what's going on. So only give it to them, obviously, if they actually need it, if they're not taking it orally. This slide, going on to the next slide, I find is quite useful. You don't have to remember every single value on this slide, but if you look at the top, it just gives you the normal plasma constituents for all the electrolytes. And the only fluids I've ever touched as an F1 and F2 is normal saline. You can give glucose, Plasma-Lyte I've seen as well, and Hartmann solution. Hartmann solutions and Plasma-Lyte, they're similar physiologically to blood plasma. So some people have a preference in giving that, where I seem to find that on surgical wards, Hartmann's is always used, and then on medical wards, they just use normal saline. I don't know why that is. I can't explain it. I think it's more isotonic that the surgeons have in their mind, that they just give it because it's more isotonic, whereas medics, for whatever reason, I don't really know why, just tend to give normal saline. normal saline is a bit more of a salty sort of fluid, as you can see from there. Hartmann's is, as I say, is just more isotonic. I'll go on to the next slide really just to show you a bit more about sort of the fluid regimes that I tend to give when I'm on the ward. So, as I say, these are the requirements that a patient's required, for like a standard adult population really. These are what they need during the day. And you know, in a sort of 70 kilogram average man, which is what everyone always drills into, you need, I think it's just over 2 litres of water and about 70 millimoles of potassium, sodium and chloride. And I don't know if you guys have heard of the 1 salty and 2 sweet sort of regime. That's what was sort of taught to me when I was a medical student a few years ago. I've never had any problems with that. 1 salt, 2 sweet, basically for 1 bag of sodium chloride and 2 bags of sort of 5% dextrose throughout the day is normally quite good. I've never had any problems with that. That's worked for me well. And obviously you supplement that with 20 millimole bags of potassium alongside that. And for some reason you always find it scary when you're writing up bags of potassium when you first start, because you think you're going to cause a cardiac arrest or something, but you're not. So don't worry about giving potassium along with it as well. And it's just important, there's no fixed, easy way of me telling you an exact regime that you can give for a patient, because it just really does vary as to what the patient is and whether they've got excessive fluid loss, whether they're overloaded, etc. So, but if you're asked, you know, for a patient who's relatively healthy on the ward, I would just give 1 salt, 2 sweet bags, and that seems to tick them over as a maintenance regime. As I say, Hartmann's and Plasma-Lyte you can use. And the other bag that NICE recommend is 0.18% normal saline and 4% dextrose as well. So this contains a bit less, it doesn't contain as much salt as a sort of bag of sodium chloride would. And you can give a couple of bags of that over the day. I've never seen it given, to be honest, and if you ask any F1s and F2s, I don't think they tend to give it either. And it's very much, I think you'll be inhibited when you start on a ward, and if you prescribe something like that, and the nurses will be like, I've never given this before, so you'll just be forced to giving a normal bag of normal saline, which is fine. But obviously, you won't be criticised for what bag of fluids you use, as long as you can sort of defend, you're trying to meet the patient's daily requirements. And based on those, if you can try and remember those 3 values at the top there, those are the values that I find the most useful. So this slide on the next one just shows a few of the values, which I'm not expecting you to, I mean, I wouldn't know all these values off by heart anyway, but it's quite useful in just showing you how much salts and potassium, etc. you lose from various regions in the body. And it just gives you an idea of how to sort of calculate and how to replete them as necessary. So yeah, always reassess the patient. That keeps being drilled into you, but it's just one of these things. It's too easy when you're on the ward for a nurse just to give you a fluid chart in front of you and ask you to give more fluids, and you just give more fluids. The 2 things as well to keeping aware of is with sodium chloride, you'll find that on some wards patients are just given sodium chloride, bag of sodium chloride after another bag of sodium chloride, and they've had like 4 or 5 bags of sodium chloride during the day, which it just isn't helping them at all. You've got to be aware of hypochloremic metabolic acidosis. You've got to have that in the back of the mind if you give too many bags of sodium chloride. I don't think I've ever actually seen it on the ward, but you know, if you're prescribing excessive bags of sodium chloride, you should keep that in the back of your mind. And Hartmann's solution, ideally you should try and avoid if there's a metabolic, a lactate acidosis rather, because Hartmann's does contain a bit of lactate in it as well. So it's difficult to reassess if you're monitoring a patient with lactate, high lactate, whether you're actually improving with fluids if you're just giving them further lactate in the bag. So I try to avoid, I don't personally use Hartmann's solution, I tend to use normal saline and dextrose, and that gets me through. And I mean, if you follow the sort of resuscitation guidelines, you've got your 500 ml stat bolus of fluids if you're resuscitating a patient, and then I've got my sort of 1 bag of normal saline and 2 bags of dextrose for the average patient on the ward for maintenance fluids. I try and work off those, and I either increase the rate of fluids if they're dry, give them more fluids, etc. Trying to calculate their losses. It is just a bit of a guesstimation when you're on the ward. But the trick is when you're on, when you've got so many jobs to do, it seems like quite a lot of stuff of information that you've got to correlate and try and ascertain. And you just have to make the best guess that you've got with the data that you've got. And if you're concerned about giving fluids, just take a step back and come back to it in half an hour, or ask someone else for some advice, really. Because I found when I started, it was the consultant would ask you to prescribe some fluids on the wards. And I don't think there's anything wrong with giving a bag of sodium chloride or anything like that at the time, but it's kind of an easy cop-out way, I think, at times, because you don't necessarily assess their fluid status appropriately, I think, and it's too easy just to work off that. So really, just to summarise, I hope that's helped really in terms of when you start on the ward, just a bit more about fluid management. Always assess the patient if you can, look at their fluid status, check their mucosal membranes, check the blood pressure, are they tachycardic, etc. It's all about assimilating as much information as you can. And look at the OBS, check the medications. Put that on the last slide here. And look at if they've got a recent echo and a recent chest X-ray. And the urine output chart as well, I find is really useful if you can make sense of it from what the nurses have written. And that's it really. I hope that's been helpful. And if you've got any questions, then go for it.
So the reason why I want to cover this one is because even as an SHO, when I see an acute confused patient, do I sedate or not? It's really tough. So I've got the right person to tell us whether that's the right thing to do. And also on falls, when I was an F1, I hate it when I get a call and say, can you come and assess this patient who's fallen on the ward? It's a pain because it will just take me an hour because I don't know what to examine. I just examine everything basically from top to bottom, and I ask them do this, and move their legs, make sure they haven't broken anything. So make sure. So if it's the right person here, just tell you actually a focus examination might be the right thing to do. Okay, thank you.
Hello everybody. So yes, thank you very much for your very generous introduction, Kerr. I'm conscious of the fact that I presume not all of you are necessarily working in Plymouth, and different trusts manage things differently. So for example, falls in Plymouth, if someone has a fall, you will be asked as the cover doctor to come and see the patient, and there's a little sticky which basically guides you through what's expected of you. But for example, in Truro, not everyone who falls gets a doctor review, at least they didn't when I left, because essentially there's a criteria for the nursing staff to give you a call if you need it. The topics are quite interlinked, and I've been just asked to talk about the on-call scenario, so I could talk to you for hours on both, but I'm clearly not going to do that. And actually, if I'm going to summarise things, it's actually quite short. So if you have any questions about either of those two topics, either as I waffle along or afterwards, please feel free to interrupt me, or anything else for that matter. Falls are important because they are very common. So there's around 700 falls in hospitals in England per day, so you will encounter them. They range in severity, and people do break hips in hospital, etc., etc. So they're important to think about. They're important to ensure your reviews are reasonable, because equally sometimes bad things happen sometime after you've seen them. And in the coroner's court, it's useful to have had a reasonable first review to demonstrate that there wasn't anything obvious at that point. So if you're asked... Oh.
The videos are from the Truro site.
Oh, you're probably not missing much if you can hear me, to be honest. I don't have any slides.
It's off from Truro there. That's, I think Kerr's phone is running out. It's on 10%. Truro,
Yep.
yeah, it might be better to turn off video from our end, actually.
Okay.
Okay? Yeah, it is.
Yep.
Yeah, you got a charger there. Yeah. Can you hear me still?
Yes.
Cool. Cool. I'll try and do it.
I'm gonna. I can.
Yeah.
So if you're asked to see someone who's fallen, you're going to be busy on call, most likely. So you will arrive at various stages. Either the person may still be on the floor, or, for example, it may be 3 hours later because you've been dealing with someone who's got a actively dying problem. So the nurses may have got them back into bed. What you need to do is not forget your basics, A, B, C, D, E type approach. That can be done quite rapidly. Check their GCS. Ask them if they are significantly, cognitively with it about what happened. If they're not, were there any witnesses? Talk to the nursing staff. Sometimes even other patients in the bay can be useful. Establish if anyone thinks they've injured themselves or if they've got any pain. And then, as Kerr says, a focused examination is entirely reasonable. The things you're worried about are that have they hit their head? Could they have a neurological injury? Have they hurt themselves or broken a bone? And do you need to x-ray anything? So that will come from your history. And in terms of examination, GCS, Kerr, I think, is fairly reasonable in terms of getting them to lift their arms up and getting them to wiggle their legs. You probably don't need to do too much more than that, because if they can lift their legs up without pain, then they're not going to have any significant breaks. If they can't, for whatever reason, then give their legs a wiggle and see if anything hurts. And if you've got any concerns, essentially just ask for an x-ray. You're not going to do any harm. Potentially have a feel down their bony spine, again, if they've landed or complaining of back pain, just to make certain they've not got any bony tenderness. And if they do, ask for an x-ray of the relevant area. In most hospitals, by the time you've done that, your shift will be over and it'll be someone else's concern. The thing that people tend to get worried about are things like neuro-obs, head injuries. What do you do with those? So NICE have some nice criteria about what to do in case you have a grumpy radiologist who quarrels with you about CT heads. And if you do, that's what your seniors are there for. So never be frightened to ask for help. Essentially, if someone's GCS has dropped by 2 points, they've had a fall from greater than 1 metre or something that's considered a dangerous position, so down some stairs. These are all sorts of indications where you'd think about doing a CT head. There are criteria for when it needs to be done, and again, the big concern for people is anticoagulation. So if you think someone has had a head injury, or you don't know if they've had a head injury and they're on anticoagulation, but they are otherwise fine, then NICE says they don't need a CT scan any more rapidly than 8 hours. But if there's any concerns with neurology, then you get a scan quickly. So if you think someone has had a head injury, essentially what you do is you ask for neuro-obs every 30 minutes for the first 2 hours, every hour for the next 4 hours, and then every couple of hours for as long as you want them. Again, by that time, shift will be over and it will be someone else's concern. Most of these situations will probably happen in the evening or on a night shift, in which case then it'll be the day team's job to pick that up. But those are your instructions to give to the nurses. If you think they've had a head injury or you're not certain and they might have done, then that's your safe approach from a neuro-obs point of view. And if they drop their GCS or there's any concerns, then essentially that's a ticket to a CT head. I asked my F1 before coming here what was the major point that he'd want to know had he had his time over again, and he said, I just want to be told that actually for people falls are really important. And that's, I suspect, the other thing he says, don't lose the fear, he said, because as F1s, when you first start and you're asked to review patients, it's often quite a daunting prospect. And he says that keeps you on your toes, and I think that's largely true. We always remember the horror stories, and those are the things that I think do keep you on your toes. We had a case either last year or the year before of someone who fell on anticoagulation for a possible PE. They fell in the bathroom and they were fine for 3 days, and then suddenly they dropped their GCS and they had a massive unsurvivable intracranial bleed. And they probably had the start of that bleed at the time they had their fall, but they were elderly and old people's brains are a bit shrunken, generally speaking, so accommodate blood before things become apparent. So had they had their CT head within 8 hours, things would probably have not resulted in death. Now that's a scare story, but it's worth remembering things like that when you see people who've fallen. Having said that, don't panic, because you will see lots of people who fall, and it's just about being systematic. And if you have an ABCD general approach, you go, I saw them, there was a story why they fell, someone witnessed, these are the injuries they might have sustained, or there were no apparent injuries, there was no complaints of pain, they could move their legs and their arms, their GCS was 15, so therefore I've left things be. That will be okay. Just make certain your documentation is clear. Any questions about falls?
Why does it need to be within 8 hours, the CT?
Those are essentially the NICE guidelines if someone's on anticoagulation and their GCS is fine. If there's any concerns, then you'd ask for it sooner. But essentially it's just to make certain that there isn't, as with the person who subsequently died, something occult happening, so you can intervene potentially at an earlier opportunity.
So any fall with someone on anticoagulation, we suspect they hit their head?
If you, yeah, they should have a head CT, essentially. Even if so, because most of the time you'll turn around and go, well, if they've hit their head and they're on anticoagulation, they're likely to end up with a great big bruise or something like that. And it's worth documenting if they don't. So if you think they've hit their head, just have a quick feel around. And just say, no signs of external head injury. But if you think they might have done, or they definitely have, but are otherwise intact, we should still be scanning their heads.
And if they're not on anticoagulation, you do neuro-obs every half hour for a couple of hours, and then if there's nothing raised, you don't need to CT.
Yeah, so if you think essentially. So the caveat with all of this is that people who are on anticoagulation at home and fall over and hit their heads don't necessarily come into hospital and don't necessarily get a CT head. But that's what, if it happens in hospital, that's what we do, or should do.
I assume you asked the nurse in your office.
Yes, yeah. Any other questions? Okay. Acute confusion ties in quite well with falls, in fairness, from both way rounds, in terms of people fall over because they're acutely confused, and people also fall over because we give them drugs because they're acutely confused. So again, if you're asked to see someone who's acutely confused, most of the time we're talking about older people who are delirious for whatever reason. And it's the same thing, don't forget your ABCD approach. Think about, common things in terms of, have they had blood tests, are there signs of infection, in terms of your initial review. There are multiple reasons why people become acutely confused, and like I say, this isn't the purpose of the talk. It's what do you do when you're asked to see them on call. So people with dementia sundown, so they get worse throughout the course of the day. Often people pootle off if you leave on time, and then the cover person has to pick up the pieces. Sometimes it's family members are around and they're settled and they leave, and again it's 8 o'clock at night that suddenly something happens and you're the cover doctor and you're asked to see them. The short answer in terms of sedation is try at all costs to not. Now on an HCE ward or a geriatrics ward, most of the time you won't be asked to sedate people unless they are really problematic. Across other parts of hospitals, you will find nursing staff who are specialised in many other areas but not dealing with the delirious older person, and therefore will ask you to try and flatten them and try and resist that, essentially. If you are going to give sedation, then they essentially need to be in some way a danger to themselves or others. And you need to document that, and you also need to document if you're going to give sedation, especially if it's not oral sedation. You need to document that they lack capacity, mental capacity, and under what reasons you're giving it. So most of the time, it'll be in a best interests decision. But those are all sorts of things that you need to document, really for your own legal protection. Ideally, what you do to try and avoid it is try and manage whatever it is that's making them delirious. So sometimes that's pain. So there's a study out there which suggested up to 2/3 of people who are delirious got better with paracetamol. Now I'm not suggesting that that is a treatment for delirium, but it gives you an idea that pain can be a contributory cause, and it's worth thinking about that. Things like being in retention, things like being told, no, you can't get up, you have to stay in your chair, things like being stuck in a bed. These are all reasons why sometimes people who are delirious just need to get up and go for a wander, but people don't have the time or the staff to do it. And that is a problem, and it's a very real problem. In situations like that, where you don't think they are being dangerous, so they're not trying to thump someone, they're not interfering with other patients, they're not really unsteady on their feet and trying to get up and therefore at risk of falls, it would be worth at least asking the nurses if they could ask for someone to come and one-to-one that patient. Because a lot of the time what someone needs is someone with them to supervise and support them, not medication. Most of the time, you will get a laugh and people will go no, and as long as they have escalated that to whoever is the senior nurse at that point, and that has been asked for, because then you are going to be seen to be doing everything you can. If all else fails and comes to sedation, then go low. So these are for, like I say, so different trusts have different policies, and wherever you work, it's worth being aware of them. NICE guidelines essentially use antipsychotics, so things like haloperidol or olanzapine are the NICE guidelines. There are benefits for those in terms of haloperidol you can give IM, olanzapine you can give as an orodispersible thing, but different trusts have different medications available. We use quite a lot of benzodiazepines in Plymouth because, especially for the older people, if you don't know what's going on, and if, for example, they have Parkinson's or might have an undiagnosed Lewy body dementia, antipsychotics can be harmful. The downside with benzos, which is also to be aware of, is that they can actually potentially prolong delirium phases. But if you're going to use something, go low. So most of the time acutely, you're going to use probably either lorazepam or haloperidol, and essentially use 0.5 of either if you're going to start, unless they're huge, in which case you might want to go with 1 milligram, but be cautious. The other thing to be aware of is how long they take to work, because if you do give it, often 30 minutes later you'll get the nursing staff going, they're still crazy, come back and give some more. And it will take at least anywhere between 30 to 45 minutes to start to work, and that's intramuscularly. And you can be talking about potentially up to an hour to a couple of hours before, and different people will tell you different things, but somewhere between that. So if you've given 0.5 and say an hour and a half later they're still rampant, you might want to give a bit more, but be cautious. And again, don't forget that you have senior members of staff who are around and normally very happy to talk. So in the worst case scenario, even if someone senior gives you the wrong advice that I as a geriatrician would disagree with, at least you've discussed it with someone senior. But be wary, and the other thing to do, because you're not going to be there, you're going to give it, or you're going to ask the nurses to give it, and you're going to be busy and asked to go somewhere else, is make certain the nursing staff are aware that they are potentially now at an increased risk of falls. Because having given something, if you don't knock them out, and you don't really want to knock them out, then they are potentially still going to try and get up, and they're going to be now more wobbly on their feet, and so are potentially more likely to fall over. So that's something that the nursing staff need to be aware of. But the message is try and avoid it, and especially when they're clearly not being a danger to themselves, they're just being irritating, essentially. That's not a reason to sedate someone.
You know when you said about, you suggest to the nursing staff that they do one-to-one?
Yep.
And, they laugh or whatever.
Yep.
And then they might escalate to their...
They should yeah. Yeah.
So, just to clarify,
Yeah.
at that point, so if the most senior nurse
Says no.
says no,
Yeah.
do you then...
So I think it depends on what is happening. And the thing is, acute confusion covers quite a lot of things. So you have people who are confused, they have no idea where they are, but they're up and about, they're wandering around, but actually they're not doing anybody any harm. And at 4 a.m, sometimes, like I say, if you're on a surgical ward, that can be quite an irritating thing to happen, but they're not doing anybody any harm. In which case, no, I definitely wouldn't sedate that person, because you then run the risk of making them wobbly on their feet and then falling and breaking something. If they are actively trying to pull things out of other people, or they're pulling out venflons and they need treatment and things like that, then yes, I would sedate. The other thing to say in that point, because again, sometimes people go bonkers overnight and they don't by day, and day teams come in and they go, but they're perfectly fine. And then if you're on nights or an evening cover shift the next night, you're dealing with the same thing. Make certain it's very clear in the notes that it's a problem, because the day team really need to try and sort things out before it becomes a problem the second night or the second evening. It's not always easy to do, and sometimes it is trial and error, but people should be trying to do something by day so it's not a recurring problem. And some specialties, or some people in all walks of life, have different interests, and some people may be a lot less fussed about it. So if the team aren't interested, at least write and say, suggest referral to healthcare of the elderly or site liaison, so that at least then they can go, well, it's still not my problem, but I'm asking for some help, because you don't want it to be an ongoing issue.
If you are not quite sure what to do out of hours,
Yeah.
who's the best person to escalate to? Is it you guys? Is it site liaison, or is it us?
So out of hours, I guess it depends which department you're working in. Forgive me, because despite Kerr's very nice introduction, I'm also quite old, so it's been a little while since I've done this for from fresh, and I do often forget about my surgical colleagues in that sense. A surgical reg, I suspect, is not going to be overly interested, and even if they are overly interested, I suspect are not going to be the best people to give you advice, because it's not something that they deal with. So if you are a surgical house officer who is having problems, then most medical regs are friendly. The times they are not, it's usually because they're busy and it's no reflection of you. And completely off topic, you will ask for advice from people who will shout at you. And that is not your fault ever at any point. You've got to do the right thing for the patient. And sometimes getting shouted at is more a comment on the person you're asking for advice than anything that you are doing wrong. So generally, out of hours, it will be a medic of some description. Most site liaison teams have working hours that don't involve being particularly, and the issue with site liaison from that point of, no, I don't mean that derogatory, but the issue with site liaison is that they are mainly interested if it is a primarily psychiatric problem. And what they will say if someone is acutely confused is there an organic cause, which you're going to be expected to think about and look into, which can be difficult if they're trying to beat you up. So in those sorts of situations, you would want to sedate so that you could do investigations and treat. But in those situations, then I would talk to a medic. And if you are, if you're a house officer on the ward and you have an SHO, then by all means give them a shout. If your next port of call is the medical reg, then that's part of the joys of being a medical reg, is being that point of contact. But don't feel bad about asking for help ever about anything.
Would you always start low, even if they are really kicking off?
Yes. Purely because you don't necessarily know how they're going to react. So you can get paradoxical agitation with benzodiazepines. So sometimes you can give benzos and people get worse. And if you go in with a big dose, you might make the problem worse. And if you go in with a big dose and you give them a respiratory arrest, ITU won't thank you. And although I have not seen it, one of my consultant colleagues always, tells me a story that he did himself as a junior, where he just kept giving increments of lorazepam every 30 minutes or so, and they had a respiratory arrest. So yes is the answer to starting low. In those situations, that's when I think I'd be asking for a little bit of support as a house officer, if I'm honest, if they're really totally, causing problems. Even if you end up only getting telephone advice, because A, it supports you, B, that by that stage, nursing staff are likely to have asked security to come and things like that. So generally, yes.
What if the patient, just by eyeballing them, looks just very large? Do you double the dose? Do you still start with like half a milligram?
So if the thing is, it depends on what you define as very large, because different people will have different definitions. But yeah, I think if someone looked very large and they were really combative, then I would go in I would go in with probably 1 milligram. The other issues, if we're talking about this, because it does get quite potentially complicated, is the other thing is, are they benzo naive? Are they naive? Because actually, if someone is already on high doses of antipsychotics or reasonable doses of, benzodiazepines, then 0.5 is going to do not very much. So it is also somewhat context dependent in that setting.
Is there ever like a pattern? Like would someone who gets a bit, when they get delirious, they
Yeah.
get hypercapacitive? Is that something that commonly occurs with a particular patient? Like, or is it just kind of random?
So, no, it's not a rubbish question. The difficulty is it's so open, it could leave me talking for a long time, which I know you don't really want me to do, I imagine.
Basically what I'm saying is if someone is delirious,
Yeah.
and they have a long hospital admission,
Yeah.
are they quite likely to get delirious and like the same kind of reaction again? Is it more common? So then you can look back in the notes and see what they've been given before.
Yeah, okay, so yes, if you've seen them go through a situation before, and so, okay, yeah, good point. Look back through the notes. Yes, you can. That's a very sensible thing to do. In terms of delirium, I suspect that's a hint. Is that a hint, Kerr?
Oh, no.
Okay.
I was just making sure that Truro was listening.
The difficulty with delirium is that people who are considered at a risk of delirium are anyone over the age of 65, which already takes account of most of the hospital, anyone having most of a major operation, which takes account of probably the rest of the hospital, anyone who's fractured anything, so your risk factors for delirium are pretty much anyone who's in hospital. So in terms of who do you worry about, well then it's pretty much anyone most of the time. In terms of if they've had an episode before, then looking back at how it was managed previously is a reasonable thing to do. The most important thing for delirium is to treat the underlying cause. None of the drugs, none of the sedating treatment actually improves delirium. It just allows you to settle and to fix what the underlying problem is. So what you really need to do is work out what's the problem and fix that. But again, that is a long list and a talk in itself.